Good morning, everyone, and welcome to the eighth edition of Sunday Special with Psychiatry Teachers. The entire program is a combined effort of Indian Psychiatry Society Faculty Training Task Force in association with Indian Psychiatry Society Undergraduate Subcommittee and Postgraduate Subcommittee. And we are running this program exclusively for people who are interested in psychiatry education. And the format of this program is that there will be a senior professor or associate professor who will talk about teaching learning related to undergraduate or the postgraduate. Then we have an assistant professor or a senior resident who is going to talk uh, anything related to psychiatry teaching and learning. Then we give few minutes for an undergraduate or a postgraduates, because in teaching learning everyone is equal and at par. So this program is exclusively running for enhancing the psychiatry education. And we finished the south zone. The state of Karnataka, Kerala, Tamil Nadu, Andhra have been subsequently completed the edition, and now we have to east zone under Dr Sujit Sarkhel, who is also EC coordinator of this program. And the entire content of the proceedings have been uploaded in the YouTube channel. Anybody who is interested can access it anytime. And we always convey that it is not the numbers which are important, it is the number of discussion and the quality of discussion, because each of you might be associated with different medical colleges, and any training which improves subsequent to this program is a great asset in enhancing the psychiatry education. With this thing, I would hand over to Dr. Sujit Sarkhel for taking over the session and introducing the speakers and further. Thank you, one and all. Over to you, Dr. Sujit.
Thank you, Dr. Kishor, and thank you very much for the introduction and the context setting. So I would just briefly introduce the three speakers for today. The opening speaker will be Professor Gautam Bandopadhyay. He is a senior professor of and the HOD of Medical College, Kolkata, and has several years of experience in teaching, with special area of interest being the psychodynamic and the psychosocial approaches. So he would be talking on re-emphasizing the importance of psychodynamic approaches for the PG students. And the next speaker will be Dr. Tamoghna Bandopadhyay. He's an RMO, basically equivalent to an SR at Behrampore Medical College, Murshidabad, and he will be speaking about whether the current COVID pandemic, actually he has been actively involved like many others in COVID duties, and he has interacted widely with the undergraduates and is widely involved in undergraduate teaching. So whether the COVID pandemic has actually changed the perspective of the undergraduates and has whether it has increased their interest towards psychiatry. So that is one area we'll be touching upon. And finally, we have Dr. Akansha Malhotra, just appeared for the final MD examination. She's still the final year resident at Institute of Psychiatry, Kolkata, and she will be speaking about her experiences and an overall how could it be PG training be more beneficial for students. She will be speaking from her perspective. So without much delay, I would like to call upon Professor Gautam Bandopadhyay to share his perspectives. And please, sir, welcome.
Good morning. Sujit, am I audible?
Sir, you are audible.
Yeah.
Very much audible.
Okay.
Could you
Thank
put
you.
on the slideshow, sir?
Yeah. Slides are visible.
Yes.
Slides. So I'm sharing my slides first. Hmm? Later. Can you see my slides?
Yes, sir. But
Okay.
the slides in the could you
Sir, it,
maximize the screen, sir?
yeah, you need, sir, the option will be below in your system. Just look the lower part of your system.
Okay.
Could you, sir, just maximize the screen and then see that icon will be visible?
Okay. You can see.
The square box. Yes, this icon, the one on the right, on the below, hourglass, the hourglass icon below.
Yeah, that goblet. Yeah. I think it's okay.
Yeah, it's perfect, sir. It's perfect.
Okay. Thank you. Uh, okay. Thank you. A very good morning to all of you. Uh, basically, mm, out of this time constraint, the first of all, I would like to congratulate for the organizers to organize such a very excellent program for our postgraduate trainees, and the for the subject selection also. My topic is the psychodynamic orientation, refocusing or re-emphasizing on in PG psychiatry teaching. Basically, I have been in psychiatric teaching or clinical practice for more than 2.5 decades, approaching just 3 decades. And what is my feeling? That is, we are deviating from the essence of psychiatry, because there are in this era of biological perspectives, actually there is a tunnel vision that is ready to accept all kinds of tools, be it psychotherapeutic as well as psychopharmacological, biological as well as psychological tools. There's a ready to act on the accessible data, the explicit surfaces, and acute symptomatic relief, thereby actually inviting a lot of problems in the form of intractability or disabilities, in the form of recurrences and relapses, patient and patient's relatives' dissatisfactions, and so many things and related complications. Uh, Unfortunately, all the therapeutic approaches, or in whatever the PGTs are being taught in their curriculum, they always claim as if they are in the famous Lewis Carroll's book novel, that is Alice in the Wonderland, the famous Dodo Varvati that all has owned and all must get the prizes. They claim they are the most effective one. But readily, we can see that all the approaches are very much time bound. We are running short of public funding in cases of mental health, and we have all sorts of algorithm related evidence based medicine approaches RCTs, and so many things. I am not in actually disliking a biological perspective, but in biological perspective is very much needed. But at the same time, we have to look after the several other perspectives that is very important for PG teaching, that is cognitive, psychodynamic, behavioral, interpersonal, social, and as well as existential humanistic perspective. That's why the slides are not changing. Yeah, it's changing. Okay.
It's changing, sir.
Yeah. So just out of just ready to reach you, particularly my dear students, that sharing my experience in the psychodynamic perspective. There are a lot of perspectives, but is it possible, is it at all okay to inculcate all forms of psychodynamic orientation in today's work? Is it worth mentioning? The points in favor of that, actually successful treatment outcome means nothing but a change in the system's meaning of a person. It is very difficult to understand the one patient's idiom of distress with mental illness. It is very difficult. Basically, in our shortcut methods, what we are doing or objectifying, that is a really reductionistic view or reductionistic approach. We need to have more than that because there are individual differences. We are collecting symptoms, categorizing, and thereby administering medicines or some form of psychotherapies. That is also time bound. But this objectification is not the essence of psychiatry. Suppose one person who sits on the chair of a patient on the opposite side of ours. If you consider him or her as subject, then the object is the doctor or the therapist, and there are a lot of expectation from the opposite end. And when the doctor or therapist is the subject, then the object is the patient. That is most often we do this. And with the course of interview, gradually we came to know that there is a term that is known as intersubjectivity. Basically, this successful treatment outcome that is related to the self-other relatedness, thereby self-other relatedness, as well as the meaning of the, making the meaning of that idiom of distress, that is very importantly dependent on the intersubjectivity of relating, because the human brain has got the potential to make this sense of we-ness. From I-ness to you-ness, there is we-ness. So initially, there are subject-object dissociation. Thereafter, they become, both the end become the subjects. There lies the importance of intersubjectivity. That is the most important part in psychiatry, because psychiatry is nothing but the science of experience. The person who came to us or brought by some other person, he or she has got certain amount of idiom of distress, as well as the pre-reflective content of affective experience and idiosyncratic understanding of their own problem, their own perception. Can you readily recognize by picking out this is delusion perception, this is delusion of reference, this is this, and thereafter providing the name of a diagnosis provisionally, tentatively, and just after reducing the certain amount of symptoms, we can claim that yes, the patient has been cured. Actually, this invites a lot of problems in the forms of relapses. That's why I have already told at the very outset. Objective science here means observation. Subjective science means meaning of that. And intersubjective science is relating. This relating phase is very, very important to us. because we have to, those pre-reflective affective importance or meaning that have never been articulated by the patient is to be articulated by the empathic understanding of the therapist or the doctor, here the psychiatrist. That is the most important part. And in today's discussion, uh, the emotional experiences, implicit processes, these are the two most important focus, as well as the developmental templates and attachment relationship. In addition to the so-called diagnostic clustering, symptom formation, collection, and so-called syndrome or symptom-specific approach. Thereby, we can reduce, and also in cases of treatment, we can reduce the further possibilities of complications, disabilities, intractabilities. At the same time, when we are assessing, that is the most important part, we are providing the meaning so that the in future, after the treatment completion, the outcome, the treatment outcome is more persistent, permanent, because there is a meaning of that distress, is a relatedness to significant others and self-other problem. That goes to more adaptive and that follows actually the trajectories of more adaptive and more rewarding ways. The essential concepts for one postgraduate trainee, first of all, they think that whether this sort of psychodynamic orientation, psychodynamic concept is readily applicable during interview. Yes, it is possible. Possibly you have know the name of Freud and his extension elaboration regarding psychodynamic perspective, where psychodynamic perspective means for a presence of unconscious as well as psychic causality for our most of the actions. That is also known as psychic determinism. And thereby we are identifying the psychodynamic factors. And we can convert all these things using just 3 or 4 pillars during interview. These are the essential concepts. First of all, we have to detect the degree of reality distortion. Then we can detect the negative transference and go or move beyond that. The most important thing is to identify the defense mechanism, different mature, immature, neurotic, or psychotic defenses, and the coping strategies, coping responses, coping styles of the person. And we can also use the counter-transference diagnostically. How? How it's possible? First of all, the reality distortion you can detect, and possibly this is the first clue by which we can detect that in my patient there is a form of there are certain underlying psychodynamic factors. Reality distortion has been equated along with psychosis, but I'm not telling about or not concerning right now about delusion. There are so many milder form of reality distortion that is evident in cases of non-psychotic patients. Suppose one lady who castigates herself for all the misfortunes in her family, the alcoholic person, alcoholic husband, who is always blaming during his interview that his wife is responsible because her criticism and the ridiculous sense of operating that criticism is actually heading actually he is more inclined for the binge habits or alcoholic habits out of this criticism. He is blaming such. Suppose one narcissist who claims that, or who actually says that the there are a lot of doctors and psychiatrists I have visited by so many of them. They are all substandard. They are all substandard qualities, and you may be the first one who can readily realize my importance, my specialty, etc., etc. These are all reality distortion because it lacks the worldview of the situation. That is important. And for one postgraduate trainee, it is difficult, primarily difficult to understand as reality distortion, but you must note that it is deviating. And just a curious mind is important to sense the interpretation of patient's motivation or other people's motivation. The patient is interpreting the way that is more important to identify reality distortion. You have to take note about this, that how the patient interprets the situation. That is important. Next one is negative transference. Negative transference, you know something about transference. Transference is nothing but this term. In simple statement, this is reenactment of our past relationship and transforming or transmuting towards the current relationship, as if the here and now experience during the interview session or assessment session, there is one transformation. In cases of positive transference, initially there are positive transferences. You just sit and relax. The person is relating or transforming the profile of some persons, that is glorifying, and just relax and sit back onto your chair. But in case of negative transference, when from the past relationship, this person of the patient might experience several difficulties in life, several mistreatment from other persons, significant other persons in his or her life, and thereby he is projecting as if you were no more different from them. So that is the negative transference, but it is difficult. But it is difficult. I am providing certain examples because negative transference is problematic. But you can sense this in clinical situation if there is tension. It is difficult. But if you listen carefully, if you sense this, you can assess, yes, there is a sense of negative transference. For some time, all of us, we have been actually, we have faced this in the form of texting, in the form of provocating statements, in the form of angry outbursts, in the form of resentments, and most of them, yesterday, even in my yesterday evening clinic, one lady who has been brought by her husband, most of the time, she, on answering my question, she used to use the monosyllables. Yes, hoga, nahi hoga. So actually, these are absolute negative transference examples because he or she is refraining from giving the correct statement. And sometimes, after some time, this lady asked me when I'm going to prescribe something after and her husband's verbatim and related. So there are so many effective, explosive outbursts in their family. Doctor, are you going to prescribe medicines? No, I can prescribe medicines or other therapeutic advice only after your science, only after your verbatim. You just say something about your problem or whether there is any problem at all. The patient, the lady asked me, Doctor, do you mean that the medicines can alter the mind? And yes, actually, I am not going into the further detail of this. Whenever the person is stating in this withdrawing or stating with some angry intermingling of emotions, basically, there is a chance of counter transference from our part. And I'm telling after one or two slides, there is a slide for counter transference also, the way we can use the counter transference. But in this case, just go on detecting this, noting this, and with your empathic, with some empathic comment, you can neutralize this. There are certain possible hidden meanings, and you have certain possible responses for that. Don't go to the counterproductive attempts of probing or chasing or otherwise describing or from your anecdotal examples, etc., etc. Don't go for that. Suppose the patient is talking, but stating, Doctor, you are not very helpful. Doctor, you look bored. Doctor, what kind of credentials do you have? Sometimes patients ask, Doctor, what is the difference between a doctor who is PhD and a doctor who is MD? Don't go into that trap. Don't actually make yourself vulnerable. You just, your empathic response or possible response would be, yes, my only credential is I have, actually we have certain credentials. That's why I am here. But I am here. My only credential is that I am here for you. I am here to listen you. That is my first criteria. When this negative statement saying, Doctor, you were not very helpful. Well, oh, you think that I am not very much helpful. But at the same time, it's very sad to hear that it seems that I am not very much helpful. Uh, Please tell what sort of things I can do, what sort of help I can provide you. Uh, Thereby, I look very helpful or at least much helpful for you. You just tell me. You don't so much understanding of what I am saying. There are very different possible hidden meaning. The doctor look that I am a special person and you need to have more special attention for me. Sometimes when the person telling the doctor, are you married? Sometimes for PGTs, it's a very common question. Suppose one person, one PGT who is going to organize one marital therapy session, etc. Sometimes it is asked, there is a kind of negative transference sometimes. Doctor, you were not married. Or the possible hidden meaning could be something others. In cases of borderline personality organization or different personality disorders, we can see so many things. Initially, negative transference was elicited in the psychological, especially in psychoanalytical setting, but though don't go for that. This is counterproductive. At least for you, you don't go for that, but you just interpret. Thereby, you can get so many psychodynamic factors. Thereby, you can assess the further problem and you can assess, readily detect the prognostic sign for that. Defense mechanisms and coping responses. All of you heard about the defense mechanism and coping responses. The clear distinction made by George Whelan, possibly you have gone through the that famous structure made by him, that is mature, immature, psychotic, and neurotic defenses. And during my assessment, if I have a ready ear for that, from hearing to listening to active listening, there is a change. And you can easily detect that there are certain transitional neurotic denial, there are passive aggression, there are projection, there may be denial of external reality, distortion of external reality. And if you go to the classification of defense, you can see that the defenses, the distinction between our coping responses and our defense mechanism are that coping responses are voluntary.
Sir, just
These are
one interruption. Time, sir, please.
oh, yeah, I'm concluding. Thank you. Uh, the coping mechanism is voluntary. Coping mechanism is constructive. Suppose I'm anticipating some dangers. I have to rehearse. I have to seek help for that. Coping styles are actually to seek help. And in cases of our patients also, suppose he or she is suffering from depression or anxiety or some other problem, the adaptive and maladaptive coping styles say many things regarding the prognosis of the situation or prognosis of the problem. And defense mechanism, this is involuntary, this is unconscious mechanism. And the more mature or more higher defense mechanism we use, the prognosis is far better. And more immature defenses, if we, during our assessment, if we are able to detect the more immature defenses, then you can sense the possibilities of personality disorder. Countertransference is that emotion is our sense of thinking onto the transparency or emotion towards the patients, and by by detecting this, we can also predict that there is a probability that the form this person is eliciting in myself also, the sense of rejection, sense of terminated, leveling the person as a bad patient, he or she is probably eliciting this response within his or her significant sphere. That is very important. And my suggestion is to do one psychodynamic formulation in addition to your diagnostic formulation, thereby the differential diagnosis on axis 1 or axis 2 conditions, ego functions assessment, adult attachment pattern, transference and counter-transference predictions, resistance, that is very important, and resistance indicates therapeutic failure also. Just writing one prescription is not enough. And therapeutic strategies and prognostic predictions we can get out of this. And actually psychodynamic formulation is a hypothesis, and with the gradual course over the interviews and sessions, there may be so many unfolding. And please do not try to be all inclusive. Focus on one or two key things. Those are the core of the patient's problem, and certain developmental experiences, certain developmental templates that may relate it to the current complaints. Stressor and trigger symptoms identifications are very important, and draw on here and now transference and counter-transference data from your interaction with the patient is very important, and predict how the patient's relationship pattern may emerge in the doctor-patient relationship and influence the course of treatment. In short, this is the psychodynamic infiltration, or rather orientation towards day-to-day practice, assessment, treatment as well. And that is important. Here lies the famous picture from modern times, 1936 film, where actually this is more akin to our situation when we are detecting, diagnosing, prescribing, but after all, there without a sense of meaning, because psychiatry is a science of experience, and if you are unable to put any meaning to that, there might not be any persistent change out of our treatment. And when the psychiatrists are just mere psychopharmacological experts or technicians, not at all the psychiatrists. Thank you.
Thank you, Professor Gautam Bandopadhyay. I think it was very, very illuminating lecture, and thank you very much. I would like to call upon my next speaker, our Dr. Tamoghna Bandopadhyay, RMO cum clinical tutor from Behrampore, Murshidabad Medical College and Hospital, Behrampore, and he will speak on the perspectives of UGs during COVID pandemic, whether it has changed. Over to Tamoghna Bandopadhyay.
Thank you, sir.
You are
Sir, I am.
Yeah. You are kindly requested to finish your presentation, preferably within 10 minutes. Now I'm going to go below to the hourglass icon, below. More to the right. Yes, below this. The hourglass icon for the slideshow. Just below the slide, where the slide has ended, on the right side, the hourglass icon, the small icon, where the percentage is written, just to the left of that.
Okay, sir.
Yes. Click on this.
Sir, I have clicked it. Has it come?
No, it has not come. Yes, it's okay now.
Okay, sir.
Slides are also changing. Start.
Very good morning, everyone, and my respected teachers, my colleagues, and my dear juniors. So today, my topic of presentation is approach to psychiatry from the perspective of the undergraduate medical students. Has the COVID pandemic changed anything? So psychiatric illness is currently the most prevalent and burning problem all over the world and especially in our country. And it constitutes the integral, essential, and pivotal component of the holistic health. But despite this conceptualization, the mental health treatment gap, that is, the number of patients who are suffering from psychiatric illness but still has not received any treatment, this is very high. And one of the most important reasons for this high mental health treatment gap in our country is poor quality of psychiatric training at undergraduate level. So psychiatry as a subject in undergraduate, it has been seen that there are much fewer psychiatrists than the actual requirement in India. That is 0.03 per 10,000 patient population. The curriculum is very limited in the medical college in the undergraduate training. It consists of 1.4% of the total lecture hours, only one short note in the final MBA examination, and a 2-week internship in a medical school, maybe less in many other parts. And so the psychiatry exposure is so few that when an undergraduate student he become a health professional, there is lack of preparation to handle the mental illness in the professional field. And now coming into the student's perspective, that from the point of view of undergraduate students, most of the students consider psychiatry as an unpopular subject. Why? First of all, there is still the stigma is very high, not only among the common people in the society, but also among the doctors of the other discipline. And the main reason of this, lack of the proper knowledge and awareness regarding the subject. It is considered tough, uninspiring, poorly comprehensible, and out of synchronization with the existing medical schema of undergraduate training. And last but not the least, though it has been improved than the previous, but still it is not a popular choice for the specialization. No.
আপনি বলবেন
19
বলুন
as multi-dimensional
ব্যবহারটা দেখুন আমার ভালো লাগছে না
কি ব্যবহারটা
কি ব্যবহারটা উনি এই কথাটা কেন বলছেন যে আমি ভালো নেই
ওনার যেটা অবজারভেশন সেটা উনি বলছেন আপনি বলুন
insecurity in employment
Mute the
these indirect psychological sequelae, they are far more important and substantial than the direct neurotrophic effects of the COVID-19 virus. And not only from the perspective of the general population, the COVID-19 pandemic has wreaked havoc among the doctors or medical professionals also. There is significant psychological impact on the health professional as well as the student. The reasons are multiple, like the loss of the loved ones, fear of contamination, prolonged work in the COVID wards day after day, dealing with the breaking bad news, and it has been seen that in many cases, the internees, just after joining the duty, they are facing with the COVID pandemic, the management of whose was uncertain at that time, and there were so many deaths. And it's a big thing to deal with when you are starting your practice or when you are starting your life in professional field. So this is an important reason for psychological breakdown or psychological turmoil. And apart from that, due to lockdown, there is chance of direct interaction. Most of the interaction is virtual, staying indoors, and also the online classes. So actually there is complete jeopardization of the normal routine activity of the students. As a result, the common mental disorder like anxiety disorder, depressive disorder, post-traumatic stress disorder, and substance abuse, they are on a high among the health professional in the post-COVID era. But one point we cannot deny that this is the first time, probably for the first time, that all the professional from the medical field, they come to realization that mental health problems, they're actually part of the day-to-day life. They are not a segregated entity which only restricted in between the asylum or lunatics or mental health indoors. It is a everyday problem and it is actually a hard-learned reality. So now I come to the actual topic of discussion today, that approach to psychiatry among undergraduate students after the COVID pandemic. Has the approach has been changed? In short, the answer is a big yes. Though it is very difficult to quantify in such small duration, but still there is a significant qualitative difference of approach after the COVID pandemic. And it is slowly starting and going towards a paradigm shift. The concepts are developing regarding the comprehensive aspect of the mental health, because previously we used to dichotomize mind and body. We used to separate psychological and physiological, psychological and organic. But now all the student and especially all the health professional, they come to realize that they are no separate entity. Rather, mind and body, they are intricately related to each other. And apart from that, another important realization is that psychiatric disorders are very much common. They are a part and parcel of our day-to-day life. And all these disorders, they have a scientific explanation and they are amenable to treatment. And if treated properly, it can lead to cure and a positive quality of life. And so can we say that COVID pandemic, though it is a disaster for the mankind, but still there is a blessing in disguise. Because definitely there is a change in approach, outlook, and perspective to the mental health. And that was the essential prerequisite to reduce the mental health gap in our country. Because there were multiple endeavors had been taken previously to integrate the mental health with the mainstream of the medical science, like the district mental health program, national mental health program, numerous 5-year and 10-year plans, all which were targeted to improve the quality of the mental health in our country, as well as to integrate the mental health care with the primary healthcare system. But it has been seen, all these endeavors, although they created some awareness, but the main aim has not been fulfilled. And the main aim of integration was not done properly because the attitude was not there, the approach was different, the perspective was not there. So the COVID pandemic has definitely changed the perspective and approach towards the mental health. And so this is a positive gain for the future of our country, to reduce the treatment gap, to improve the quality of life, to improve the mental health of the people in general. And so this gain have to be maintained. And if it can be maintained, it can go a long way to improve the mental health infrastructure as well as the manpower in the near future. So now automatically the next question comes, how to maintain? What can be done to maintain this gain or benefit? So unless and until the gain is maintained or consolidated, the everything we achieved in the field of the mental health, that would be gone back to oblivion. So one thing that the Medical Council of India has implemented in 2019 in undergraduate curriculum, that is the competency-based teaching. And in this competency-based teaching, significant weightage has been given to psychiatry. And a positive effort has been given for horizontal as well as vertical integration with other subjects. The main focus was to build competency on the suicide, common mental disorder, Mental Health Care Act, neurodevelopmental disorder, the mental ethics, and development of the communication skill and rapport with the patient. So apart from that, what we feel that the change in teaching approach is also very important to induce positive approach as well as to promote psychiatry interest among the undergraduate training. Because we all know that psychiatry is a very linguist and literature based subject. There is extensive vocabulary use, and most of the undergraduate students find it very difficult to comprehend at their stage. So avoiding such extensive use of the linguistic and focusing on use of day-to-day language or vernacular language to avoid the stigma of, and not only stigma, it is actually dogma of psychoanalysis, and much more focus on the biological perspective of the various psychiatric disorder. All this approach or all this effort can improve the interest of the undergraduate student in psychiatry. And last but not the least, we have to encourage consultation liaison psychiatry at undergraduate training. There is actually 2 weeks of rotatory internship in the psychiatry. And we all know, considering the vastness of the subject, it is nearly impossible to get a glimpse of the overview of psychiatry in this 2-week rotatory internship. So what we need that to integrate psychiatry in various other disciplines so that the student can get aware of the comprehensive aspect or holistic aspect of the subject, and they will learn that there is basically no difference between psychiatry and other subject of the medicine or subject of the surgical field, and every system or every disorder can have some psychiatric consequences and vice versa. So regarding conclusion, psychiatry was a long time ignored subject in undergraduate training, and lack of awareness and the prevailing stigma has made a negative approach to the subject. And now the COVID pandemic, it was an eye-opener. It shows us the importance of psychiatry, or rather the mental health, in our daily life. And the changes of approach are noticeable and substantial. And to promote the long-lasting effect, the change need to carry forward so that we can improve the mental health of the professional of the medical field. We can improve the knowledge of the student. We can improve their interest in psychiatry, their participation in psychiatry, and in the long run, it will increase the manpower in psychiatric field or mental health care field. And this lack of the manpower and lack of the resources is the cardinal reason for the treatment gap or mental health gap in our country. So if we can consolidate our gain, we can achieve positive mental health and positive mental well-being in the near future. So thank you everyone, and I I sincerely thank to Indian Psychiatric Society for considering such beautiful program, and the subject is very pertinent in today's world or in modern times. And I sincerely thanks Dr. Sujit Sarkhel sir for giving me this opportunity to speak here. Thank you.
Thank you, Tamoghna, for such a incisive presentation. Definitely has given us many new insights. Thank you for your perspective. Now I would like to call upon Dr. Akansha Malhotra, final year PG resident, just appeared for the exams, and she will briefly talk about uh, the neglected areas of psychiatric training, what she has felt during her entire training period, and as well as her interaction with other PG trainees from other institutes. So what, according to her, are the neglected areas which we should keep in mind? Over to you, Akanksha. You have 10 minutes to present your perspectives. Thank you.
Good morning, everyone. Sir, I'm audible, sir?
Yeah, you're very much audible and your screen is visible. It's full screen.
Good morning, everyone. Today, I'll be sharing my views on the topic. What were the neglected areas of PG psychiatric training? Now, starting with India, postgraduate training started in 1941. Indian Psychiatric Society formed a committee on postgraduate medical education in the same year of its inception, that was in 1947. Medical Council of India began regulating the postgraduate training in 1956, and training is also provided through Diplomat of National Board courses, which were established in 1975. PG training has primarily been focused on gaining clinical experience by the way of postings and communication. Training is aimed to prepare the students to become qualified psychiatrists with the ability to work independently. But the training that students receive today have an impact on the professions and society of tomorrow. To make them better psychiatrists, there should be an ongoing effort to improve the psychiatry training that the postgraduate receive. I will be covering the problems I faced during my junior residency under the following headings. The first was ignorance of the psychosocial assessment and intervention. The absence of relative lack of psychological approach and interventions by psychiatrists is one of the major reasons for dissatisfaction with the psychiatric services. Psychiatrists of the future should be equipped with the skills to meet the expectations of the evolving society. And there's an increasing recognition of therapeutic interventions such as cognitive behavioral therapy in the management of psychiatric illness. Psychological interventions by the trainee psychiatrist should be planned, documented, supervised, and evaluated for every patient. But many departments do not have an adequate number of psychologists, and the psychologists who do stay on the postgraduate departments are often overburdened with clinical work and find it harder to focus on supervisory roles and actively participate in the postgraduate training. It is difficult for them also to be present on rounds with us, which impacts postgraduate training and builds a vicious cycle of reduced exposure to non-pharmacological interventions. More exposure to psychological aspects can be done through joint programs with psychologists. Human resource scarcity for psychotherapy training should be tackled by steps like student exchange programs or focus workshops. Feasibility of examining the psychotherapy skills of the trainee in a separate practical examination is also worth considering. Coming to the academic program, a well-organized academic program greatly enhances the value of a postgraduate program, and we were blessed to have a systematic schedule of classes and lectures at our institute. But it would be of great benefit if guest lectures of our faculty from elsewhere in the country could be organized, which will permit an exposure to various approaches and perspectives. Students require adequate teaching about the principles of drug management, management of emergencies in psychiatry, and understanding of the basis of important policies which are present for the care of mentally ill. Periodic demonstration of the skills to translate theory into actual practice by senior consultant is also helpful for students, as such demonstration and discussion empower them. There's also need for interdepartmental needs for case discussions. That is the discussions between departments of psychiatry, neurology, neuroradiology, and endocrinology. Such interdepartmental discussions manage us to help to manage systemic diseases with psychiatric manifestations and also side effects of psychotropic medications like antipsychotic induced amenorrhea or lithium induced hypothyroidism. Now, over the years, the scope of psychiatry has widened and the psychiatric training is not limited to training only in general adult psychiatry. For a holistic and complete training program, besides adult psychiatry, there is also need for adequate exposure to child and adolescent psychiatry, geriatric psychiatry, addiction psychiatry, consultation license psychiatry, forensic. Different types of psychotherapies are also important, and so as neuroimaging, electroconvulsive therapy, and brain modulation treatments. By discussing neurology, though we have our postings for neurology, but the greater focus is on CNS pathology. There is less focus on higher mental functions and soft science, which is more interest to psychiatrists. And whenever there is a possibility of organicity, an imaging should be done where both psychiatric and neurologic consultation should be obtained. The focus in neurology training should shift to cognitive assessment, skills to interpret neuroimaging, and electroencephalogram and rehabilitation. For coming to clinical approach, problems cannot be handled solely going by diagnostic criteria, nor can be managed blindly following guidelines like instructions out of a cookbook. Problems of the patients will not make sense if the clinician does not make efforts at understanding the person as he or she is in the context of where the patient comes from, their background, their ideals, morals, and culture dictated norms. The skills involved in doing so cannot be completely acquired by reading textbooks, but rather they are acquired by clinical observation and supervision. Approach to diagnosis is an area that needs to be consistently worked on, as diagnosis cannot be reduced to a sum total of diagnostic criteria only. Hence, the importance for clinical skills cannot be underestimated. These years of training in psychiatry perform the distinctive role of both serving as kindergarten years and the highest levels of learning. I believe that the research methodology training workshop should be started at least after the first 3 months of the postgraduate training, and there should also be an additional training in statistics and statistical software. Protocols with timelines for the dissertation should be developed by each department to reduce the chances of late submission. And also taking part in another study should also be encouraged. Students should be encouraged to publish their own dissertation data without waiting for final examinations. The current pattern of postgraduate final examination, especially the internal assessment, has no uniformity across the country. There should be a more dynamic year-round performance record with regular feedbacks, which should become a larger portion of the certification process. And also, more importance should be given for continuous internal assessment rather than a single exit examination. The problem which the undergraduates face that the exposure during MBBS is very less, and the primary care physicians trained in psychiatry is a way forward. Greater exposure to psychiatry during undergraduation will kindle interest in some students to take up the field. And also there should be a separate paper or at least a separate section in the MBBS curriculum with a separate examination. The posting in psychiatry in UG post should at least be for 4 weeks. But the challenges we faced during COVID-19 pandemic was that the lockdown measures forced inpatient and outpatient psychiatric services to significantly reduce their clinical capacity and limited access to services. These adjustments impacted face-to-face interactions, thereby limiting educational, supervision, and mentorship activities for trainees. Resources dedicated to research and to enrolling patients in clinical trials were also reduced, and at the same time, many psychiatric trainees and consultants were redeployed to non-psychiatric wards, effectively interrupting regularly scheduled training activities. Academics during COVID-19 period were also decreased due to lockdown and social distancing. which could have been overcome by more number of virtual classes on an online platform. Now, I would like to conclude my presentation with following suggestions: that there should be more emphasis on training in psychotherapy. There should be a shift from didactic model of learning to discussion-based learning, including organization of frequent workshops. Interdepartmental case discussion should also be increased. There should be adequate exposure to various specialties, including child, geriatric, forensic, and consultation licensed psychiatry. And lastly, exposure during MBBS training for development of interest in psychiatry in the future. I'd like to end the presentation with a very good quote by Sir William Osler, that it is important to know the diagnosis, but it is more important to know the person who has got the diagnosis. Thank you so much.
Thank you, Akanksha, for finishing on such a lovely note. It was a beautiful presentation highlighting precisely the important points which can be of concern. I would just like to re-emphasize what has been put in the chat box, that the source of resources, important resources for all students interested in psychiatry and the psychiatry teachers, the Indian Teachers of Psychiatry on the ITOP website. So that is there. We are a little short of time, or rather we have finished the presentations with very little time for discussion, but considering the fact that such nice presentations have been done, we can have a few quick questions. So since we do not, do we have questions in the chat box? No. So anyone can unmute and ask a question. Since we have little time, we can have a few questions, considering the presentation has been so nice and elaborate. So please be spontaneous.
I have a question. I was really impressed with Gautam sir's presentation. I wanted to know what kind of training is being imparted for postgraduates on psychodynamic approach in their institution. How are they encouraging the postgraduates to do it? Sir?
Thank you. Thank you, Dr. Rao. Actually, right now, as such, there is no definite protocol we are following in our institution, but we are planning for that, because while our postgraduate trainees are assessing or interviewing a person, they have to give at least one very listening ear on the defense mechanism, detection of defense mechanism and resistance. That is very important. Right now, possibly I overheard from OP sir's screen when he was unmuted, the possibility there was a conversation in Bengali that the lady, the woman voice was telling, the, sir, are you considering that I am not well just after receiving something from my husband? That's all. We can, this sort of conversation are very common in our OPD settings. And suppose one person who has got no insight for that, but he or she is quite resistant regarding taking medicines or regarding compliance. So first of all, just to identify defense mechanisms, identification of negative transference and resistance, what I do like to say that this is a practice. I cannot advocate any such protocol for learning this. This is the simple practice make our responses, our empathic responses for that. And with this listening ear, but actually that was widely prevalent in whenever we were students. In our studentship, our teachers like Ellen Sarma, Dr. Nandi, Dr. Ajita Chakraborty, they were quite fond of this, and they always told us that just actually you have to develop your ears and your mind so that you can feel that. So we have a plan for that, and to add one psychodynamic formulation in addition to the diagnostic formulation, to know the prognostic factors as well as the persistence of stability of the person, so that their life can go with fully adaptive or more rewarding ways. But I think. Thank you.
Thank you, sir. I think it's a very apt thing. Very interesting that the postgraduate also, Dr. Akanksha, at the last slide, she said the postgraduates are interested to learn psychotherapy. So it makes a lot of sense. And one end, teachers want to revisit psychodynamic approach, and on other end, postgraduates are interested to learn. So I think it's a wonderful combination of keen interest in. Apart from the biological approach. Thank you. Thank you so much, sir. Over to you, Dr. Sujit.
Okay, any other quick question? Anybody?
Yes, hello, sir. My name is
Yeah, yeah.
Dr. Sujoy.
Yeah,
I was
please.
Hi. I was working up to recently in India. I have recently migrated to UK and started working here. Um, I would just like to ask anybody on the panel or anybody on this thing regarding undergraduate teaching. What is the better way of doing it in psychiatry rather than only clinical postings? I have seen some places here in UK where they actually give students, undergraduate medical students, to write formulations of cases. I thought it was a bit too much, but the students seem to enjoy it. So what is the thought of the panel here on things like advanced things like formulation and all for medical students?
So for training for undergraduate students, I think Dr. Kishor can take that. He has been doing it for so many years, UG and PG teaching. Dr. Kishor, your thoughts on that? Dr. Kishor?
Sorry, I missed. There was network issue. I could not hear. Yeah.
Oh.
Can you please?
Dr. Sujay, could you just repeat the question?
Yeah.
Yeah, sure, sir.
Just briefly. Yeah.
My question was, what is the thoughts on teaching things like advanced things like writing case formulations to undergraduate students? I've seen some people in the UK, in the medical students and all, those are writing proper formulations, or they're at least trying to do that in their undergraduate itself. So things like formulation, biopsychosocial model, how do you put it to undergraduate students? How do you simplify it?
Okay, that's a very interesting question at this point of time, because psychiatry itself is not a major part of the curriculum in the undergraduate psychiatry in India. The first progressive step is that they have made some changes in the way we teach in competency based curriculum. But what they have interestingly done is that we can have electives in psychiatry. So, if you come out with electives in psychiatry, any undergraduate can do little more learning in psychiatry, and there is an opportunity for them to teach formulation and other things. The other related aspect is that at the undergraduate level, we never knew how much we should teach about mental status examination. So, for the first time, Indian Psychiatry Society Karnataka chapter has come out with a document which will be discussed extensively on what is our consensus about mental status examination for postgraduates and undergraduates. So, once we are very sure of how we accept the mental status examination training, then the subsequent approach will be how do we help the undergraduates learn about formulation, how to write a summary. These are all extended part of psychiatry training at undergraduate level. I hope with so many people trying to do something in their institution, we should be improving upon that part. But at currently, where there is very less scope for taking psychiatry in undergraduate aspect in India to the level we expect. I hope I have answered. Dr. Sujit?
Yes,
Yeah.
thank you, sir.
Thank you. I can take another question. Anyone from the audience? Okay. I would finally, before wrapping up, I would finally invite Mohan Isaac sir, who has always been with us and logs in and always encourages us, for his final comments before we wrap up the session. Over to you, sir.
Thank you, Sujit. As always, it has again been a very useful Sunday morning listening to three people. I was just thinking, today we have been lucky because we listened to not one Bandopadhyay, but two Bandopadhyays. I don't know whether in Bengal there is any significance, but I think it is not often that in a meeting, in the same session, that you listen to two Bandopadhyays. That is, of course, in a lighter way. In India, especially in the past, including the period that I have been a trainee as well as uh, um, initially trainee at NIMANS doing my MD and subsequently a faculty at NIMANS, whenever we think of psychodynamic uh, practice, psychodynamic training, etc., we always look up to Calcutta for obvious reasons, because that is where I don't have to say that to largely people from the eastern zone of Indian Psychiatric Society. And of course, Gautam mentioned about his own teachers, many of whom I have personally known very well. In fact, particularly Dr. D.N. Nandi, who used to be a frequent visitor to NIMATS. And I think for one of my promotions from lecturer to assistant professor, he was the expert who came. Ajita Chakravarti, of course. So it has been very refreshing to listen to Dr. Gautam talking about a topic which is not very popular in India these days. He has mentioned about that. He was, of course, using terms like reductionism, etc., etc. But Dr. Gautam, this is not just a problem in India. It's a global problem. In fact, I think it was Melvin Sapshin, who was the APA's secretary, who said psychiatrists in America who are getting trained, there is a danger that they may forget how to talk to patients because everything is on a prescription pad. The psychopharmacology role is steadily increasing. In fact, just about 2 weeks back, I was just going through Alan Francis' book called Saving Normal, where he is, of course, talking about medicalizing normal behavior. He was, of course, criticizing the DSM-5 for increasing the diagnostic categories. But the other important point he made is that there are powerful forces playing behind this, that is a psychopharmacology industry. So, Gautam, you have picked upon a very popular topic. I have full sympathies and empathy with what you have done, but there should be a critical mass of teachers who believe in what you said. In fact, I have noted that in my note taking, the point that you said fairly early in the beginning of your talk, we are deviating from the essence of psychiatry. Something to that effect was also heard in Akanksha's talk when she said, no, there has to be psychotherapy training. In fact, the first point was that the biggest problem in postgraduate training is ignoring psychosocial assessment and interventions. So that is about Dr. Gautam's talk, but I don't know how this will, how this can be implemented, because the whole area of postgraduate training, there are lots of flaws. I will, of course, refer to that, referring to Akanksha's talk, because she has very, very ably pointed out some of the flaws, which many of us are aware of, but we are not able to, simply solve it. And I think what the ITOP does with all the Sunday special, etc., are little efforts to change this. And also, I would like to reinstate the point which Kishore mentioned that, last Thursday evening, I was listening to an IPS Thursday music programs. At the height of it, at the height of the program, there were 300 people. I logged in because one of my old friends and colleagues and students, Dr. Geeta Desai, was talking. So 300, and today we have 20, 25, 30. But the point which Sujit mentioned, Kishore mentioned, not only people who are participating, but the resources are available. In fact, all the current edition, Kishore said, is the 8th edition, but all other editions of the Sunday Special are available on YouTube by going to the Indian Psychiatry Teachers, Indian Teachers of Psychiatry website. So, in response to Gautam's talk, I think it is a need of the hour, but we need to slowly build up by talking about it and build a critical mass of teachers who not only are able to teach but are deeply interested in this area. The second talk was, I was again keenly, looking forward to Tamoghna's lecture, because in the title he had put 3 question marks. So that increased my curiosity. He was asking approach to psychiatry from the perspectives of UG medical students. Has the COVID pandemic changed? 3 question marks, not just 1 question mark. Of course, question marks and exclamation marks also communicate. So I was keen to know what he's going to say, and I must say that I was very interested, because these post-COVID changes everywhere in people, in their economy, everything we are learning, it will continue. We do not know when the COVID is going to end. That was a very useful talk. But I must say that I thoroughly enjoyed the third speaker, Akansha Malhotra's talk. My first comment is that, Akansha, you have hit at all the important points. And I think you are a very good psychiatric teacher in the making. Because as a third year, final year student of MD, if you could identify all the important points, the ignoring of psychosocial factors, the lack of research training. In fact, in many PG centers, we teachers ask students to do journal review, critically comment on the statistical method, etc., without really training them on research methodology. How can they critically review a journal article if we have not taught them? So she has highlighted the need for research training. Another important point is, of course, psychiatry has a poor image in medical schools, many medical schools, not only in our country, but all over the world. And one of the reasons why this is so, and one of the things that we should do as psychiatrists to elevate the status of psychiatry, is what Akansha mentioned, and that is interdepartmental case discussions. I mean, we probably can improve consultation liaison psychiatry in every hospital by actively participating in medicine, surgery, case discussions, and taking some of our cases to them. But very often we shy away. We say, though, we have too much caseload, etc., etc. But unless you do this, unless you show other medical colleagues the worth of psychiatry, psychiatry will continue to be a neglected specialty. There are lots of things written about the hidden curriculum, how our own medical colleagues are the ones who perpetuate stigma against psychiatry, etc., etc. So it has been, once again, anything which comes from a PG trainee is very useful. And I think Akanksha should write it up. I had said the same thing. I don't know whether it was last Sunday meeting or an earlier one, but there are pearls of wisdom. And in demands with a few people, most notably Dr. Prabhachandra, we have been trying to develop some kind of a, postgraduate journal. This is Dr. Prabhachandra, who is a professor of psychiatry. She has been talking to me about this for some time. I don't know what stage it is now. The reason why I'm saying is that when you, Akanksha mentioned another point, all MD theses should be written up and published. You go to any medical college, you look at the MD thesis which are there. Of course, the library gets a copy. There'll be lots of theses which have not been written up or published at all. So these are all very good points. Akansha, your presentation should be written up and published. Last point I wanted to say, I believe that these resources which the ITOPS is generating is very important. In fact, just yesterday evening, I recorded a talk, an invited talk for the World Congress of Psychiatry, which is taking place between 18th and 21st in Colombia. Now, it was thought to be a physical conference when it was planned 1.5 years ago, but because the COVID is there all over the world, it has become a virtual conference, and that's why I had to record my talk. It's a presidential symposium on undergraduate psychiatry education. Anybody who is interested to see that presentation, just send a mail to me. I'll be happy to send it to you, or you can even send the mail to Kishor. Kishor has a copy of that. In that, I have tried to publicize the ITOPS website, because in a 12 or 15-minute talk, you can't say everything about what are the problems in undergraduate training and postgraduate training. And we believe that the Sunday specials are trying to fulfill that gap in a little way. I would end here, and I would again thank Sujit for personally sending me a mail reminding me. I may or may not have remembered. Sunday mornings are important for most people. I believe that is one of the reasons why not many people attend Sunday. In the olden days, Sunday mornings, you used to go for a morning show. These are my student days, because at that time we didn't have Netflix, we didn't have Amazon Prime Video. Sunday morning was the best time because you don't have to go for rounds even as a postgraduate student. But while morning shows may not be there, I think all people have lots of other things to do on Sunday mornings. So thank you very much. Back to you, Sujit.
Thank you, Mohan Isaac sir. As usual, beautiful rounding up of the whole thing and the words of encouragement for the speakers and important take-home points. With that, I come to the end. My apologies for having overshot the time a bit, but I think you have even enjoyed the extra minutes. I felt they were necessary, and I promise that we'll have same time, probably the last Sunday of October, and we'll come up with another program. And so I take leave from all of you, wishing you all the best and a happy Sunday. Thanks for being there. Thank you, everyone. Thank you, Kishore. Thank you, Isaac sir. Thanks all the faculties.